All right, so we have made it to the planning portion of the nursing process. The planning phase, or actually the planning and outcome phase, is when we plan for nursing actions. So some keywords to know. Planning, well, is establishing patient goals to prevent, reduce, or resolve the problems identified in the nursing diagnosis and determination of related nursing interventions. Ongoing planning is carried out by any nurse who interacts with the patient to keep the plan up to date. Outcome identification is observation of the patient to demonstrate the resolution of the problem identified by the nursing diagnosis and general problem list. Patient outcomes are expected conclusions to a patient health problem, or in the event of a wellness diagnosis, an expected conclusion to the health expectation. So this is kind of like your planning and your picking out the goals for your patient regarding that nursing diagnosis that you came up with. So what are we planning? Well, we're planning our patient care, the goals we want to set up for them, or their outcomes. So basically, we want to establish priorities, identify and write expected patient outcomes, select evidence-based nursing interventions, and communicate the plan of care. So establishing priorities would be, so when you identify your nursing diagnoses, what is the most important thing you want to do first? So we talked a little bit about the type of priorities in nursing diagnosis and how we use Maslow's hierarchy of need and using that to establish priority diagnoses. We identify and write expected patient outcomes. So with that, we want to write our goals for this patient. So we want to identify what the outcome we want for this patient. The selective evidence-based practice is for nursing interventions is when we what are the things that we're going to do so that we reach our patient outcomes, so the interventions that we provide. And then communicate the plan of care. So this is kind of like the documentation part, plus the many ways that you would communicate the plan of care in whatever facility that you work at and whatever their established policies and procedures are. But that plan of care would be continued or taken away if the patient meets the outcomes. But the oncoming nurse would need to know these things, so we need to be able to communicate them. So what does the plan of care allow the nurse to do? So it helps individualize care that maximizes outcome achievement. It sets priorities, facilitates communication among nursing personnel and colleagues, promotes continuity of high quality, cost-effective nursing care, coordinates care, evaluates patient response to nursing care, creates a record used for evaluation, research, reimbursement, and legal reasons, promotes nurses' professional development. So setting priorities is one of the big components of planning and outcomes of a plan of care. And then individualizing the care that maximizes their outcomes. So we, what this is called is patient-centered care. So we get this nursing diagnosis. We plan specifically for this specific patient, and then we do our interventions, and we hope that this patient meets their outcomes. And it is always specific to the patient. So you will notice as you get into your nursing career that you can see 10 COPD patients, and Individually, you will see how different they are and how they deal with their disease, and how we as nurses use the nursing process to individualize care per that patient. So it is something that as you get into your career, you'll be able to do and create that patient-centered care and individualize it for their, so that the outcomes are achieved with much greater possibilities. And remember that the plan of care and the outcome identification and planning part of the nursing process is designed for you and your patient to participate. So we want the patient, to know what we're planning on doing, so that they're involved in their own care, give some independence, and this will help the patient with, once implemented, that it can result in prevention, reduction, or resolution of patient health problems. And then we can see and identify if the patient has met their outcomes. And if the patient agrees because they were involved in their plan of care, then we have done our planning and outcomes correctly. There are 3 elements of comprehensive planning during the outcome planning stage. Elements or stages of the first one is the initial, which is developed by the nurse who performs the nursing history, the physical assessment, addresses each patient problem listed, and prioritizes nursing diagnoses. They identify appropriate patient goals and related nursing care. An example of the initial would be if the nurse is receiving a brand new patient onto their unit that they've never taken care of, but they would start all this process. So, it starts with assessment, then moves on to diagnosis, and then the planning and outcome stage. And so they are the initial nurse to start that plan of care. Then the ongoing part is carried out by any of the nurses that interacts with the patient. So if the patient that the last nurse was their initial patient, now any nurse who encounters this patient does the ongoing comprehensive planning. So they keep the plan up to date. They manage risk factors, promote function, states nursing diagnosis more clearly, develops new diagnoses as things change, make outcomes more realistic, and develop new outcomes as needed. They identify nursing interventions to accomplish patient goals. So this nurse, or any nurse that encounters this patient, will continue to work with that planning and outcome so that they can see if they've met outcomes, if they need to get rid of things, if they need to add things, if the patient's condition changes, then they need to change certain things. And then there's discharge planning, and the discharge planning is carried out by the nurse who works most closely with the patient, begins with when the patient is admitted for treatment, uses teaching and counseling skills effectively to ensure that home care behaviors are performed competently. To note that discharge planning is actually something that starts when the patient is admitted into a new unit. This part will go hand in hand with the initial, because as someone gets admitted to the hospital or to your unit, we want to start prioritizing goals on how to get them home safely, or wherever they're going to be sent to safely, so that they have the best outcomes. So we want to prioritize our planning and our outcomes Um, Again, we go back to our Maslow's hierarchy and need. So we want to meet the physiological needs of the patient, then safety, and then loving, belonging, esteem, and then self-actualization. But the physiological needs can be anything from breathing, food, water, sleep, homeostasis, and excretions. Um, the way we do it is we want to prioritize the nursing diagnoses through some form of ranking, so high, medium, or low priority. So high priority diagnoses are the ones that pose the greatest threat. And then medium ones are priorities that are of medium threat. They still need to be done, but if that high priority stands first, we definitely need to work on that high priority first. The medium ones are not usually specifically related to the current level of health, but are still important for the patient. And then low priority would be anything else that is not causing the patient any immediate danger. It may not have to do anything with their current diagnosis and things like that. Another way we prioritize is patient preference. That would be patient needs to, I'm trying to think of an example here. So say the patient has been in an accident and has to be admitted to the hospital. Well, the patient is now very worried about something going on at home, so maybe the care of their child or their pet or anything like that, that they withdraw and don't want to participate in their care. So then, we ask the patient what they want to do, like if they need to call home or they need to call somebody, and then we could probably move on to those higher priority things. Another one is an anticipation of problems. So that could be that the nurse can see that a future problem will develop, and then knowing that it might need to be prioritized better. So, and this is why there's always an ongoing planning and outcomes, because as a patient, whatever's going on with the patient, things can change pretty quickly. And so any nurse that interacts with this patient can begin to make a plan and prioritize for the best outcomes. So this is a list of ways that you can use clinical reasoning to establish your priorities. So what problems need immediate attention and which ones can wait? So in an emergency situation, say you have a patient who is in a car accident, is bleeding profusely, but the patient is combative and trying to fight the nurses because they are confused or whatever is going on, that they are being combative. So what needs immediate attention? How would we decide what we need to do first? Well, the nurse wouldn't be able to take care of that patient if they are trying to get violent with you, but they are also bleeding profusely, so they would need to intervene in some way so that they can offset maybe that combativeness of the patient, and then be able to help that bleeding. Again, which problems are your responsibility, which you need to refer, or which ones do you need to refer to someone else? So this again is having to know what your scope of practice is to what other people can do. Which problems can be dealt with using standard plans, so such as critical paths, standards of care, algorithms, and things like that. Those are things that you will learn through your career that you're going to be able to prioritize based on standards of care. Um, which problems are not covered by protocols or standards but must be addressed to ensure safe hospital stays and timely discharge. So uh, these are type of things like maybe a patient example. I think one time I had a patient who um, didn't speak English and was very confused and had a broken leg, but we could not, um, going with any standards, figure out where we could place her after hospital discharge because there was no next of kin. There was no, it was very hard to plan for her discharge because it was very hard to communicate with the patient. There was nobody that she had next of kin. And the patient, I think, wound up being in the hospital for a good, I think it was a long time. I don't even remember. But it took a long process of elimination to get a timely discharge for her because a lot of the things didn't fall under the protocols or standards that the hospital had. Ongoing would be has the patient had any changes like in their health status that can change the priority of your diagnosis? Are the relationships among diagnoses that required one be worked on before another can be resolved? So that's just kind of also prioritizing, uh, figuring out which one you need to do first before you can do the next one. And sometimes you can deal with several patient problems in one deal. So these are just some things that you would look for while you're doing your clinical reasoning and trying to prioritize exactly what you want to do. So learning to identify and write appropriate outcomes does take some practice. Here we have just some general types of outcomes that us as nurses deal with. So we have the long-term versus the short-term. Long-term outcomes require a longer period to be achieved and may be used as a discharge goal. And then short-term outcomes are short-term outcomes may be accomplished in a specific period of time. Usually, sometimes these short ones can be shift specific. So you're taking care of this patient and your short-term goal for that shift is the patient will not get out of bed unattended throughout my shift. This is just me making up a goal. This is just thinking about something that I usually want my patient to do if they are a confused patient. I don't want them to get out of bed unattended. To note, a lot of long-term goals are usually greater than a week, and they take longer to achieve. That's why they say they can be used as discharge goals because we don't expect them to happen like that day or the next day. And with the short-term goal, we can maybe sometimes expect it to happen in a day, but it can still be something like my goal, the patient outcome or goal would be not to get out of bed for the whole 24 hours. So, and it's just timing wise, you should know that a long-term goal is usually more than a week. Some factors that you want to consider when selecting outcomes is the type of health concern, the nursing or medical diagnosis, patient characteristics, available resources, patient preferences, and treatment potential. Um, as we continue to learn about patient-centered care, we want to make sure that we always involve our patients. We even ask them what goals they want to achieve while they're in the hospital, what they um, want to do by discharge. So, and it's always dependent on what is going on with the patient. So we can say, if we talked about our COPD patient, so he wants a goal of feeling less fatigue. And we have to look and see, what is this something that the patient will be able to achieve while they are in the hospital, or is this something that has to be long term as they come together in their COPD diagnosis? So the categories of outcomes are as follows. So cognitive describes an increase in patient knowledge or an intellectual behavior. An example of this would be for our COPD patient, that would be the patient will list the benefits of pursed lip breathing. The psychomotor one describes patient's achievements of new skills. So this would be the patient will demonstrate deep breathing exercises by so-and-so date. The affective one, which is kind of one of the harder ones to do, describes the change in patient values, beliefs, and attitudes. This could be an outcome such as, by date of so-and-so, the patient will verbalize the importance of seeing their primary care provider routinely. That one is just kind of a little harder to set because it is sometimes very hard to change a patient's values and beliefs and attitudes. However, it is still a type of outcome that we do want to work for. So to write, or what are the parts of the measurable outcomes? Really, writing patient-centered and measurable outcomes are kind of under the same umbrella. On one thing, you need a subject, a verb, condition, performing criteria, and a target time. So an example of this would be the subject for us right now at this moment is our patient, which his name is Jal Jones. So we would say Mr. Jones, and then the verb is the action we want them to perform. And this is dependent on the type of outcomes that we want. So, define, list, explain, describe, verbalize are just some common words that we're going to be using. The condition would be the particular circumstance for the patient. So this is how we will achieve the outcome. And not every outcome specifies a condition. The performing criteria is the expected patient behavior or other manifestation that described in an observable, measurable manner. The target time is when we expect a patient to achieve their outcome. So this is very important because as we write our outcomes, we need to have a target time for that outcome. So that can be a realistic date, or maybe something like before discharge, or after viewing this video of education, or things like that. So it is just kind of like that measurable time limit. So using the acronym SMART can help you create your measurable outcomes, because you need a You need a specific goal. It needs to be measurable. It should be attainable, realistic, and time bound. So again, with that target time. So that time bound is still that when you want this outcome to be completed. You have to remember with the measurable outcomes, you want to be able to show in your plan of care whether they have been met or not met. And that way you can further evaluate if you need to change the plan of care, or if the patient has met their outcome, then they um, don't have to continue doing that portion of the plan of care or that plan of care specifically. So that is why it's always important to make it measurable so that you can see if the patient has met their outcomes. So these are just some common errors in writing your patient outcomes. Expressing patient outcomes as nurse intervention. So the patient will drink so and so ounces of fluid. Or using verbs that are not observable or measurable. So these are the words such as learn, becomes aware, they understand, because those type of verbs are not truly measurable, and we do need something that we can observe and measure. Including more than one patient behavior or manifestation in a short-term outcome. So this would be such as the patient who say is here for alcohol addiction. So the goal is the patient will list the dangers of alcohol use and will stop drinking alcohol. So that is just kind of too broad. The two things separately could be goals and likely long-term goals, just because a short-term goal doesn't have enough time for us to really truly meet that patient would stop drinking, especially if we know that alcohol addiction is probably one of the hardest addictions to quit, and so we know that is not something that's going to happen in a day or two. Writing vague outcomes, so that's pretty specific. The patient will feel better. Well, that's not very specific. Doesn't really, it's not measurable. How would we know the patient feels better? So these are just common errors that you'll run across, and as you're learning to write these outcomes, you may have those errors, but it's okay, and we'll definitely work through them so that by the end of this program, you'll be able to write those patient outcomes specific to the patient, that are prioritized based on their needs. But this is just kind of like the introduction of that. All right, so you guys made it to the end of the planning and outcomes slide. So next we move on to our implementation of the plan of care.